Good day, medical students. Our topic for today is your leukocytes or the white blood cell, and we're going to discuss the process of phagocytosis. As for our reference, as you all know, we take it from Guyton and Hall, 13th edition, chapter 34, resistance of the body to infection, leukocytes, granulocytes, the monocyte, macrophage system, and inflammation. So that's our topic for this lesson. You can also find it in your Ganong's Review of Medical Physiology, and some of the images here are taken out from Google Images. Now, these are the objectives and outline of this lesson or this topic. I won't bore you with it and I won't read it anymore. Now, let's start first in defining what are leukocytes, or our white blood cells. Leukocytes are the mobile units of the body's protective system. They are formed partially in the bone marrow, especially your granulocytes and monocytes, and a few lymphocytes, and are partially in the lymph nodes, your lymphocytes and your plasma cell, or your matured B cells. After formation, they are transported in the blood to the different parts of the body when and where they are needed. The real value of our white blood cell is that most of them are specially transported to areas of serious infection and inflammation. Thereby, they provide a rapid and potent defense against infectious agents. So this is our immunity or immune system. The granulocytes and monocytes have a special ability to seek out and destroy any foreign invader or antigen. Now, there are several types of white blood cells. We have your polymorphonuclear neutrophils, polymorphonuclear eosinophils, polymorphonuclear basophils. We have your monocytes, which will eventually become your macrophage, your lymphocytes, your T and B cells, and the mature B cells that secretes your antibodies are what we call as your plasma cells. Now, the adult human being has about 7,000 white blood cells per microliter of blood, compared to the 5 million red blood cells per microliter. So anything less than 4,000 of white blood cell, we consider that as your leukopenia. So leukopenia refers to a decreased number of your white blood cells. And anything above 11,000 count of your white blood cell, we call that as your leukocytosis. So leukopenia, decrease. Leukocytosis is increase. Now, there's a reason why they call it polymorphonuclear. It means, for the name itself, their nucleus, the cell of that nucleus, is changing in shape, or it doesn't have a definitive shape. That's why they call it poly, has many morpho shapes, or they morphologically change depending on which structure or which cells are we talking about. Okay? So the polymorphonuclear or PMN neutrophils account for 60% of the white blood cells in our body. The eosinophils accounts for 2.3. Polymorphonuclear basophils account only 0.4. So that's around 1% or less than 1% in our white blood cells. And we have your monocytes, which accounts for 5.3%, and lymphocytes, which account 30% or the second most numerous white blood cells in our circulation. So how will we remember this, Dr. Bautista? About the number. We have a mnemonic that we follow in medicine that our white blood count. Never let monkeys eat banana. Never stands for neutrophils, which accounts for 60%, which we mentioned a while ago. Next is your lymphocytes, your T and B cells, which accounts for 30%, and monocytes, which accounts for 6%, eosinophils for 3, and the least of them all are your basophils. So always remember when they ask you how many percent or which is the most numerous in our body, we always say the neutrophils at 60%. Never let monkeys eat banana. Okay, or you have your 60, 30, 6, 3, and 1. So you can easily remember the percentage of our white blood cells. So now let's discuss how we form your white blood cells. The process of forming your white blood cells or leukocyte is called your leukopoiesis. It starts in the bone marrow with our pluripotent stem cell. Another name for that is your hemocytoblast or your hematopoietic cells. They can differentiate in two major lineage, your myeloid stem cells or your lymphoid stem cells. Both are stimulated in your bone marrow from our stem cells. Now, in your myeloid stem cells, if our body needs more RBC, our kidney will secrete our erythropoietin or EPO to stimulate the myeloid stem cells to form more RBCs or your reticulocytes. When our body needs more platelets, our liver and portion of it comes from the kidney will secrete what we call as your TPO or your thrombopoietin, which will stimulate the myeloid stem cell to produce megakaryoplasts, which will eventually become our platelets. Now, this is the main topic of our lesson on your leukopoiesis. How do we form your white blood cells? Now, there are two basic lineage for your myeloid stem cells. Your granulocytes and agranulocyte. One has granules, the other one doesn't have granules. Now, depending on the need of the body, especially in times of infection or inflammation, our myeloid stem cells can differentiate into your monocytes, which are considered agranulocytes. They don't have any granules. Or they can produce your neutrophils, eosinophils, and basophils, which are also called as your granulocytes. By the name itself, they have granules. Now, with the stimulus of your interleukin 3 and interleukin 5 and your agranulocytes, colony stimulating factor or your ACSF, will now produce your monocytes from your myeloid stem cells. Now, if our body has your interleukin 3 and interleukin 5 and also your granulocytic colony stimulating factor or your GCSF will now produce your neutrophils, basophils, and eosinophils. I think this picture will show you it better or will explain it better. Again, from our histologic stem cells, will produce your myeloid or lymphoid stem cell lineage. From the myeloid, we can produce our platelets for our TPO by the influence of this hormonal factor on your myeloid stem cell. It will become a megakaryoblast and eventually a megakaryocyte, which will blast through our bone marrow and shred by that process and eventually become our platelets. Now, if our body needs more erythrocytes or RBCs, our kidney will secrete your EPO or erythropoietin, which will influence your myeloid stem cells to become your pro-erythroblasts and eventually your reticulocyte and now your erythrocytes. That's why, my dear students, some patients that have chronic renal failure or problems with their kidneys and it cannot produce your EPO, they also suffer from anemia because they cannot produce that many erythrocytes because of the decrease in production of your EPO. But that's another topic for your red blood cells. Okay, now let's concentrate on your white blood cells or your leukophoresis. As what I mentioned, we have two types. You have granulocytes, or which has cells which has granules, and agranulocytes. Okay, depending on which our body needs during the time of infection or inflammation, that will influence your myeloid stem cell to become your myeloblasts and your monoblasts. Okay, the myeloblasts, due to interleukin 3, interleukin 5, and granulocyte stimulating factor, will produce our basophils, neutrophils, and eosinophils. These three cells are what we call as your polymorphonuclear cells, right? As you can see from their nucleus, it has plenty of shape or it has no definitive shape because it can form plenty of shapes inside the cell. Now, if you remember your basic histology, acidic stains like eosinophil stains are negative in charge. So it means that the eosinophil cells have a positive amino acids or proteins inside. That's why they turn red in color. Okay, acid stains. Eosinophils are acid stains, while your basophil stains are your basic stains, or they contain positive charge, which attracts negative amino acids or ions inside of the cell, which they appear blue. That's why basophils appear blue. Now, in your neutrophils, it contains both the amount of positive and negative charge. That's why they call it neutral, neutrophils. Okay, they appear at least reddish to bluish in color. Okay, so those are our myeloblasts or granulocytes. Now, for our agranulocytes, the monoblasts, thanks to our interleukin 3, interleukin 5, and agranulocyte stimulating factor, it will develop into your monocytes. Now, this monocyte, when are circulating in our blood, will go eventually to the different parts of our body or different tissues in our body. In that tissue, they will become the resident macrophage system. Okay, it means that if that monocyte goes to your kidney, they eventually become their Kupffer cells. If it goes to your lungs, they become our alveolar cells or our dust cells. In the skin, they can eventually become our Langerhans cells or your dendritic cells. The next lineage in our WBC or leukopoiesis is your lymphoid lineage. The lymphoid stem cell will eventually become our lymphoblasts, depending on our body's needs again, and will become your natural killer or large granulocyte lymphocytes or small lymphocytes. Remember, these are 30% of our white blood cells, which will divide and mature to become your T lymphocytes and B lymphocytes. T lymphocytes if it matures in your thymus, B lymphocytes if it matures in your bone marrow. And once activated, those B lymphocytes will become your plasma cell. So a plasma cell is an activated or mature B lymphocytes. These plasma cells, my dear students, are eventually the cells that will secrete our antibodies. Okay, that is now our leukopoiesis. So now let's discuss the lifespan of your white blood cells. The life of the granulocytes or your neutrophils, basophils, and eosinophils after being released from the bone marrow is normally 4 to 8 hours only, circulating in our blood, and another 4 to 5 days in tissues where they are needed. Let's say if they reside in your skin, liver, and other part of different organs in our body. In times of serious tissue infections, this total lifespan is often shortened to only a few hours because the granulocytes proceed even more rapidly to the infected area, perform their function in which they have to kill and sacrifice themselves. In the process, they are themselves destroyed. The monocytes, however, also have a short transit time. They only stay around 10 to 20 hours in the blood before wandering to the capillary membranes into the different tissues. Once in the tissues, they swell to become much larger to become the resident tissue macrophage. So as what I mentioned before, our monocytes will travel in your blood. They stay there around 10 to 20 hours. And then once they reside to the tissue, they become the tissue's macrophage system. And in this form, they can live for months unless they also sacrifice themselves to destroy while performing their phagocytic functions. That's why they call them as your macrophage. They can eat big or they can eat a large amount of antigens or foreign invaders. Lymphocytes enter to the circulatory systems, your T and B lymphocytes, continually, along with the drainage of lymph from the lymph nodes and other lymphoid tissues. After a few hours, they pass out of the blood back into the tissues by the formation of your diapedesis, or they can transit for one portion of our body back into the blood by diapedesis. Then they re-enter the lymph and return to the blood again and again as part of their circulation. Thus, this is a continual circulation of lymphocytes to our body. The lymphocytes have lifespan for weeks or months, depending again on the body's need for these cells, or if they can have a function of killing pathogens, of course, they will have a shorter lifespan. So now let's discuss your neutrophils and macrophage. This too is the phagocytic cells in our body that can attack and destroy invading bacteria, viruses, and other injurious agents, which we call as your antigens. Neutrophils are considered as your microphage. Okay? While monocytes that eventually become macrophage, they are considered macro or big eaters because of their size. The neutrophils are mature cells that can attack and destroy bacteria even in the circulating blood. That's one of the big difference as well. Please remember, your macrophage, they swell when they go to your tissues. Hence the name macrophage because they can also seek out and eat and destroy big and numerous numbers of bacteria. While the capability to phagocytize and attack and destroy bacteria in our blood is inert with your neutrophils. But, they can only phagocytize or eat in a small amount. That's why they are called as your microphage. Okay, or they are considered as your microphage. But the good thing about them is that they can do it in or while circulating in our blood. Now, tissue macrophage begins life as blood monocytes, which are immature cells while still in the blood and have little ability to fight infectious agent at that time. So that's one of the big difference between the two. Neutrophils can phagocytize even in the blood, while your monocytes, which are not yet macrophage, remember they're still in the blood, has little ability to fight those infectious agents. Now, macrophage, once they enter to the tissue, they begin to swell and sometimes increase their diameters as much as fivefold to a great as 60 to 80 micrometers, a size that can barely be seen by the naked eye. Now, these cells are now called as your macrophage, and they are extremely capable of combating disease and agents in the tissues. Now, white blood cells, your neutrophils and monocytes can squeeze through the pores of the blood, which a process which we call as your diapedesis. They can squeeze through small spaces in our capillaries. That is, even though a pore is much smaller than a small portion of that cell slides through the pore at a time. The portion sliding through is momentarily constricted to the size of that pore. Now, when the white blood cells move to a tissue or space, they move in a amoeboid motion. So please remember that. It is often asked in the exam. Okay, they move in an amoeboid motion. Some cells move at a velocity as great as 40 micrometers per minute, a distance as great as their own length each minute in that movement. Now, when white blood cells are attracted to inflamed tissues, they are attracted because of your chemotaxis, okay, or the chemicals that attracts them to that site. Many different chemical substances, like your interleukin, tumor necrosis factor, your even for the viruses, right? You have your interferons. The tissues can both neutrophils and macrophage to move toward to that source of the chemical. This movement or those attraction to that source because of that chemical is what we call as your chemotaxis. They move to that chemical agent. Okay? So that's our white blood cells. Chemotaxis, as what I mentioned, when a tissue becomes inflamed, at least a dozen different products that can cause chemotaxis toward that inflamed area. That concentration is great, of course, in that source where you have that injury or that antigen or infectious agent. Chemotaxis is effective up to 100 micrometers away from that inflamed tissue. So the radius of that uh, chemicals can reach into 100 micrometers. Almost no tissue area is more than 50 micrometers away from one capillary to the next. So it means that that 100 micrometers, you will definitely have a capillary stimulated. So there will be migration or diapedesis of our white blood cells. Chemotactic signal can easily move or hordes of WBCs from the capillaries into that inflamed area. Now, there are different products that can cause chemotaxis or that attraction of our white blood cells, your neutrophils, or even your macrophage system. Some of the bacteria or viral toxins, definitely, they can attract your white blood cells because those are foreign. Even the generative products of inflamed tissues, okay, of our cells, that is a potent chemotactic factor. Several reaction products of the complement complex activated by inflamed tissues, and several reaction products caused by plasma clotting in the inflamed area, as well as other substances. Our platelet, our complement system can definitely attract your white blood cells to that area of bleeding or inflammation. Chemotaxis depends on the concentration gradient, of course, of the chemotactic substance. The greater the chemotactic substance, the greater of reactions of your white blood cells. So let's learn about now your phagocytosis, or the act of cellular ingestion. Phagocytosis is the most important function of our neutrophils and macrophage. That's why they are called phagocytic cells. It means cellular ingestion of any offending agents. In the blood, neutrophils; in your tissues, it's your macrophage. Okay? Phagocytes must be selective, of course, of the material that is phagocytized. So, class, please remember that your neutrophils and macrophage are very selective on what they eat. So should you be selective on what you eat also. Otherwise, normal cells and structures of the body might be ingested. So do not ingest anything that you see or even entices you. Whether phagocytosis will occur depends especially on three selective procedures, according to Guyton. One is the most natural structures in the tissues have smooth surfaces, which resist phagocytosis. However, if the surface is rough, its likelihood to be phagocytized or to be eaten by your neutrophils and macrophage. Okay, so they don't like smooth surface. Most natural substances of the body have a protective protein coat that repel that phagocytic cells. Now, conversely, most dead tissues or destructed tissues and foreign particles have no protective coat that we were talking about, which makes them subject to that phagocytosis. Okay, so again, as a review for number 2, our natural substance in the body has a protective protein. Now, any disease entity that can destroy that or trauma that can destroy that can be subject to phagocytosis. The immune system of the body will develop antibodies. That's why we have your vaccines and we have those plasma cells secreting those antibodies against infectious agents. Now, once they tag it or opsonize it, especially in your bacteria or viruses, it is likely to be phagocytized by your neutrophils and your macrophage. Okay, so the antibodies then adhere, as what I was mentioning, to that bacterial membrane, and they make the bacteria especially susceptible to phagocytosis. To do this, the antibody molecule also combines with your C3 product of your complements to produce that complement cascade. Now, that C3 molecule in turn attached to receptors on the phagocytic membrane, thus initiating that phagocytosis. This process by which the pathogen is selected for phagocytosis and destruction or tagging, we call this as your tagging, is called your opsonization. So that is what happens. As you can see, these are antibodies surrounding this bacteria in which it activates or it is being tagged by that antibody for your phagocytic cells, neutrophils or macrophage to be eaten. Okay, so this is what we call as your opsonization. So to show you a diagram of it or to explain it further, I have this video for you.
Phagocytosis. The entrance of materials with big molecules into a cell is called phagocytosis. At this process, initially, the food particle is coiled up through the false feet produced by the cell membrane and is engulfed into the cell. The structure is formed by the false feet coiling the food particle separates from the cell membrane and forms food vacuole in the cytoplasm. As a result of the food vacuole merging with lysosome, the enzymes in the lysosome digest the food particles into their building blocks. The digested food particles move into the cytoplasm, and the waste materials are discarded out of the cell through exotosis within a contractile vacuole.
So let's concentrate now on the phagocytosis by your neutrophils. As what I mentioned, neutrophils entering the tissues are already mature cells that can immediately begin phagocytosis. Now, on approaching a particle to be phagocytized or to be eaten, that neutrophil first attaches itself to that particle and then projects a pseudopod in all directions around that particle. So it's like they are surrounding that particle or that bacteria or virus. That pseudopodia meets one another on the opposite side and then it will fuse. This action creates an enclosed chamber that contains the phagocytized particle. Then the chamber invaginates to the inside of the cytoplasmic cavity and breaks away from the outer cell membrane to form what we call a free-floating phagocytic vesicle, also called as your phagosome. So once inside in that cytoplasm, that particle is now called as your phagosome. A single neutrophil can usually phagocytize around 3 to 20 bacteria before the neutrophil becomes inactivated or eventually dies. Okay? So they become unuseful already once they eat around 3 to 20 bacteria. Now, for your macrophage, they are the end-stage product of our monocytes, as what I was been mentioning, that enter to the tissues from our blood, from your monocytes. When activated by the immune system, they are much more powerful phagocytes than our neutrophils, often capable around 100 bacteria. So if we have around 30 for your neutrophils, your macrophage can phagocytize as many as 100 bacteria at a time. They also have the ability to engulf large particles, even whole RBCs or occasionally malarial parasites. Whereas neutrophils are not capable of phagocyting particles that much larger than your bacteria. That's why they call them as your microphage. Also, after digesting particles, macrophage can extrude the residual products and often survive and function as many more months compared to our neutrophils. So when I say extrude, it's already dead by their lysosomes. Okay? Now, please remember, in phagocytosis, once a foreign particle has been phagocytized, lysosomes and other cytoplasmic granules in the neutrophils, especially your neutrophils, remember, they are granulocytic cells. They have granules. Or macrophage immediately comes into contact with that phagocytic vesicle, and their membranes fuse, thereby dumping many digestive enzymes and bacterial agents into that vesicle. That phagocytic vesicle becomes a digestive vesicle, and digestion of that phagocytized particle it begins immediately. Both neutrophils and macrophage, they contain an abundance of lysosomes. This is their killing material, my dear students, filled with proteolytic enzymes. From the name itself, it can destroy protein chains, especially geared for digesting bacteria and other foreign protein matter. Now, the lysosomes of macrophage, but is not found in your neutrophils, also contain large amounts of lipases. So from the name itself, lipases, you know that it can digest the thick lipid membrane possessed by some bacteria such as our tuberculosis bacillus. Okay, so lipases, inert for your macrophage system. Now, neutrophils and macrophage contain bactericidal agents also that kills most bacteria even when the lysosomal enzyme fail to digest them. Okay, let's say they escape those lysosomes. They have another backup killing material. This characteristic is especially important because some bacteria have protective coats or other factors that prevent their destructions by those digestive enzymes. Much of the killing effect results from several powerful oxidizing agents formed by enzymes in the membrane of the phagosomes or by special organelles which we call as your peroxisomes. So if they escape those lysosomes, the backup mechanisms are your oxidizing agent. and your peroxisomes. This oxidizing agent includes large quantities of your superoxide, hydrogen peroxide, and your hydroxyl ion, which are lethal to most bacteria even in small quantities. One of the lysosomal enzymes are your myeloperoxidase. They catalyze the reaction between your hydrogen peroxide and chloride ions to form your hypochlorite, which is exceedingly bactericidal. So that's a combination of your hydrogen peroxide and chloride ions. So now let's discuss your reticuloendothelial system. What do we mean by your reticuloendothelial system? After entering the tissues and becoming the macrophage, another large portion of your monocytes becomes attached to the tissues and remain attached for months or even years until they are called on to perform that specific local protective function. They have the same capabilities as the mobile macrophage to phagocytize large quantities of bacteria, viruses, necrotic tissues, and other foreign particles in the tissue. Now, when they are appropriately stimulated or they are offending agents, they can break away from their attachment and once again become mobile macrophage that responds to chemotaxis and all of the other stimuli related to that inflammatory process. Now, this body's widespread monocyte macrophage system is virtually present in all the tissues. Total combination of monocytes, mobile macrophage, fixed tissue macrophage, and few specialized endothelial cells in our bone marrows, especially your spleen, lymph nodes, is what we call as your reticuloendothelial system. So this is a picture of your reticuloendothelial system. As you can see, we start from the stem cell, from the bone marrow, which eventually will be secreted as your monocyte, and that monocyte will become now the resident macrophage. And from the stem cell, we also have your polymorphic nuclear cells, which are your neutrophils, eosinophils, basophils. We can also have your platelets, and as what we mentioned, your macrophage, once they become resident in the tissue or they reside in that specific tissue, they become the macrophage of that tissue. For example, they reside in the kidney, we call them as your mesangial cells. They reside in the lungs, we call them as your alveolar macrophage or even your dust cells. They reside in our brain, we call them as your microglial cells. In the skin, they are called as your Langerhans cells. In your tissues, they are called sometimes as your histocytes. In the liver, we call them as your Kuffler cells. In the lymph nodes, you are your follicular cells. And even in your intestinal wall, we call them as your MALT or mucosal activated lymphoid tissues. Okay, so that is the future of our macrophage system. The reticuloendothelial system, they are the tissue macrophage in the skin, subcutaneous, macrophage in the lymph nodes, alveolar macrophage in the lungs, we call them also as your giant cells, dust cells, macrophage in the liver or your sinusoids, we call them as your Kupffer cells, and macrophage in the spleen in the bone marrow, we call them as your white pulp or even your red pulp. So now let's discuss inflammation. When the tissue occurs, injury, or there's injury in our tissue, whether caused by a bacteria, trauma, chemical, heat, or any other phenomenon. Multiple substances are released by the injured tissues and cause dramatic secondary changes in the surrounding injured tissue or uninjured tissues. There will be this characteristic of inflammation. You have your calor or the heat or the increase in temperature, rubor, which means redness, dolor in Latin, which means pain, and then tumor or swelling, which are the functional lesa or the functional characteristic of inflammation. So you have an increase in temperature or heat, calor, rubor, or there's redness, dolor, there's pain, and tumor, there's swelling. This entire complex of tissue changes is what we call as your inflammation. Again, it is characterized by vasodilation of the local blood vessels with consequent excess local blood flow. There's increase in permeability of the capillaries. Again, because if you increase the size or you have vasodilation, those spaces allows leakage of large quantities of fluid into that interstitial space. Now, often clotting of the fluid in the interstitial space because of increased amounts of fibrinogen and other proteins leaking from that capillary. So that's the characteristic of our inflammation. Now, there's also migration of large numbers of granulocytes and monocytes into that tissue, and of course, swelling of that tissue. Now, some of the many tissue products that causes reactions are your histamines, bradykinin, serotonin, prostaglandins, and several different reaction products of the complement system, reaction products of the blood clotting system, and multiple substances called as your lymphokines that are released by synthesized T cells as part of our immune system. So these are the products released by your leukocytes. Okay, so several of these substances strongly activate the macrophage system, and within a few hours, the macrophage begins to devour and destroy that tissue, that damaged tissue or that infected tissue. Now, there's what we call as a walling effect of that inflammation. One of the first results of inflammation is to wall off or to surround the area of injury from the remaining tissues. My favorite example for this, my dear students, is your insect bites. I'm sure most of you have experienced a mosquito bite or an insect bite. What do you see after insect bite? Do you see a square, triangle, or rectangle swelling in your skin? Of course, it's a circular swelling where it walls off circularly that prevents the spread of that saliva or that poison or that antigen from that insect. The tissue spaces in the lymphatics in the inflamed area are blocked by fibrinogen clots so that after a while, fluid barely flows to that space. This walling off process delays the spread of that bacteria or toxin or products. So, the intensity of the inflammatory process is usually proportional to the degree of tissue injury. Oh, doctor, I was bitten twice. Of course, you don't expect a small wheel or small circle. You expect a bigger one because the intensity of that inflammatory process is proportional to the degree of that tissue injury. Now, for example, when a staphylococcal invades your tissue, they release extremely lethal cellular toxins. As a result of that, inflammation develops rapidly, indeed much more rapidly than your staphylococcal can multiply and spread. So, therefore, the local staphylococcal infection is characteristically walled off rapidly and prevented from spreading throughout our body. So, if you come to think of it, my dear students, that is a protective mechanism of our immune system. Okay, so here in the picture, you will see the migration of the neutrophils from the blood into that inflamed tissue. You see the cytokines and other biochemical products of that inflamed tissue cause increased expression of selectins. So what are those selectins? These are the selectins and intercellular adhesion molecules, or what we call as your ICAM molecules. Selectins and ICAM molecules are expressed or increase in expression into those endothelial cells of our capillaries and blood vessels. Now, these adhesion molecules will bind complementary to the molecule receptors of those neutrophils as if they are guiding those neutrophils to that site of injury, causing it to adhere to the wall of the capillary or venule. The neutrophil then migrates to the vessels by diaphydesis. Or remember the diaphydesis that we are talking about a while ago. Okay? Towards the site of injury of our cells and tissues. Now, the macrophage and neutrophil response during inflammation. Remember, tissue macrophage provides the first line of defense against infection. Neutrophil invasion of that inflamed area will act as a second line of defense. Acute increase in the number of neutrophils in the blood, which we call as your neutrophilia. Second, macrophage invasion to that inflamed tissue is a third line defense. So we're calling another portions of macrophage. Increased production of those granulocytes, macrophage, neutrophils, eosinophils, basophils, whatever type of the infection, and monocytes by the bone marrow is in the fourth line of defense. We stimulate their production. And then there's a feedback control of that macrophage and neutrophil responses. And eventually, these two will form our pus. Okay? So that is the macrophage and neutrophil respond during our inflammation. So this is a diagram of it. As you can see, bacteria and other pathogen, because you have an open skin or open wound, will now invade that skin. Platelets from blood release blood clotting proteins into that site, so it will try to wall off and so decrease the spread of those bacteria. Mast cells will now secrete that vasodilation and vascular constriction, delivery of that blood, plasma, and cells into that area. Okay, so these are the mast cells. They will secrete now vasodilating effect and vascular constricting effect. We mean by vasodilation, they open up those spaces and surrounding vasoconstriction so that it won't spread to the nearby areas of your blood. Neutrophils secrete factors that can kill and degrade those pathogens. Are the lysosomes, that vesicles that we were talking about a while ago. Now, that macrophage secrete hormones, which we call as your cytokines, and these cytokines will further call on other macrophage and attack immune system cells on that site of injury and also activate cells, especially your antigen presenting cells, which will be involved in tissue repair. Now, inflammatory response continue until that foreign material is eliminated and that wound is closed or repaired. Okay, so now let's talk about your eosinophils. We're finished now with your neutrophils and your macrophage. Now, eosinophils, they constitute, as what we mentioned, about 2% in the blood leukocytes. They are weak phagocytes and they exhibit chemotaxis. But in comparison with the neutrophils, it is doubtful that eosinophils are significant in protecting the usual type of infections. They are often produced in large numbers in people with with parasitic infections, and they migrate to the tissues of that disease parasites. So they are increased in times of parasitic infections. Almost Although most parasites are too large to be phagocytized by those eosinophils or any phagocytic cells, eosinophils will attach themselves to that parasite by way of special surface molecules, and then they will release substance that can kill many of that parasite. So when they attach, they will now release those granules so that it can kill that parasite. One of the most widespread infection is your schistosomiasis. It is a parasitic infection found in as many as one-third of the population in some developing countries like in Asia, Africa, and South America. The parasite can invade any part of our body. Eosinophils will attach to them and to the juvenile forms of the parasite and kill many of them. They do so by releasing hydrolytic enzymes from their granules, as what we mentioned, which are already modified lysosomes of your eosinophils. Probably by also releasing high reactive forms of oxygen or high reactive oxygen species that are especially lethal to those parasites. By releasing from the granules a high larvicidal polypeptide called as your major basic protein. So this is highly larvicidal that can destroy the larva of those parasites. In a few areas in the world, almost parasitic disease that cause eosinophilia is your trichinosis. The disease results from invasion of the body's muscles by your porkworm or your trichinella parasite after a person eats uncooked infested pork. So luckily for most of my Indian students, that especially are Muslims, they don't eat pork. But for us Filipino who loves to eat pork, they are susceptible in ingesting this parasite. Okay, so this is a diagram of your eosinophils in action. They will release those lysosomes even though they are not big enough to kill that parasite or that helmet or that worm. They will attach to them by your antibodies or to their cell surface and release those granules inside that can eventually kill those helminths. Okay? So there, they love to attach themselves to your IgE or your IgG or to your complement system. Together, They attach to that parasite and bore a hole to that parasite. So on the right, these are examples of your larva in which your eosinophils are in action. As you can see, they surround them or they increase in number and able to trap them and eventually kill them. Okay? So eosinophils also have a special propensity to collect in tissues in which allergic reactions occur, such as in your peribronchial tissues of the lungs in people with asthma and in the skin after your allergic reaction. This action is caused at least partially by the fact that many mast cells and basophils participate also in these allergic reactions. Mast cells and basophils will release your eosinophilic chemotactic factor that causes your eosinophils to migrate toward to that inflamed allergic tissue. So because of this two, and they release your eosinophilic chemotactic factor, your eosinophils will be attracted and will increase in number. The eosinophils are believed to detoxify some of the inflammation-inducing substances released by those mast cells and basophils, and probably also phagocytize and destroy allergen antibody complexes, thus preventing excess spread of that local inflammatory process. So these are your mast cells. They are responsible for allergic diseases, parasitic infections. They can also increase tissue remodeling, innate immunity, and acquired immunity. They're also both involved in that. Autoimmunity and angiogenesis, or forming of your new blood vessels, and even in your tumor. In your eosinophils, as what we have discussed, they are allergic. They are present in allergic diseases. They are antigen-presenting cells. They increase in helminth infection, tissue injury, and even in your tumors. Okay, so let's go now to your basophils. The basophils in your circulating blood are similar to the large tissues mast cells located immediately outside many of the capillaries of the body. Both mast cells and basophils, they liberate or they secrete heparin into our blood. So you know heparin is a substance that can prevent blood coagulation. Mast cells and basophils also release histamine besides heparin, as well as small quantities of your bradykinin and your serotonin. Now, please remember, it is mainly the mast cells in inflamed tissue that release this substance during inflammation. The mast cells and basophils play an important role in some type of allergic reaction because of the type of antibody that causes allergic reaction. Your IgE has a special propensity to become attached to those mast cells and basophils. So your IgE, they love to attach to your basophils and to your mast cells. Now that attachment of antigen to antibody causes that mast cells or basophils to rupture and release those large quantities of what we mentioned, histamines, bradykinin, serotonin, and heparin, and even slow-reacting substances for anaphylaxis. Now, there are a number of lysosomal enzymes also, which now in turn will cause our allergic manifestations. Heparin is preventing blood coagulation, so you will have seepage of that blood. Histamine, bradykinin, and serotonin will give you inflammatory reactions. That's why, my dear students, allergic reactions are considered as a medical emergency because it can trigger different cytokines in our body as well. Okay, now to the last part of our lecture, let's discuss your leukopenia. Leukopenia are very few WBCs in our body. So leukopenia connotes that the bone marrow produces very few WBC. Now this condition leaves the body unprotected against many bacteria and other agents that might invade our tissues. Now any decrease in the number of WBC, as what we mentioned in the first part of the lecture, less than 4,000, immediately allows invasions of adjacent tissue by bacteria that are already present. Within 2 days after the bone marrow stops producing your WBC, ulcers may appear in the mouth, in our colon, and in some of our severe respiratory infection might develop. Bacteria from those ulcers rapidly invade surrounding tissues and eventually will go to our blood. Without treatment, death often ensues in less than a week that after acute total leukopenia begins. Okay, so that's the problem with your leukopenia. Now, what can cause leukopenia? Irradiation of the body by X-rays and gamma rays or those who are undergoing radiotherapy or exposure to drugs and chemicals that contain benzene or anthracene nuclei is likely to cause aplasia of the bone marrow. Aplasia of the bone marrow means that they cannot produce those cells or white blood cells. Some common drugs, such as your chloramphenicol, thiouracil, which we prescribe to our patients that has thyrotoxicosis or published in their thyroid gland, okay, or even various barbiturate hypnotics on rare occasions can cause leukopenia, thus setting the entire infectious sequence into this malady. So please be careful in prescribing to our patients this type of drugs, especially when you know that they have already decreased in WBC. After moderate irradiation injury to the bone marrow, some of the stem cells, your myeloblasts, your hemocytoblasts, may remain undestroyed in the bone marrow and are capable for regenerating that bone marrow. But if it cannot regenerate, it won't provide sufficient WBC in our body. A patient properly treated with transfusion, with antibiotics and other drugs to ward off infection usually develops enough new bone marrow within weeks 2 months for blood cells concentration to return back to normal. Okay? Now, other sickness or popular sickness when you have decreased or uncontrolled production of their WBC are your leukemias. Uncontrolled production of your WBC can cause by cancerous mutation of your myelogenous or your lymphogenous stem lineage. That's what we mentioned a while ago. This process causes leukemia in our body, which is usually characterized by greatly increased number of abnormal white blood cells in your circulating blood. Okay, this is the one I was mentioning in our first part of the lecture. When you produce blast cells, when you have increase in blast cells, you have increase in immature or ineffective white blood cells. Lymphocytic leukemias are caused by cancerous production of your lymphoid cells or lymphoid lineage, usually beginning in the lymph node and other lymphocytic tissue and spread to the areas of the body. When there is your myelogenous leukemia, it begins the cancer production of your myelogenous cells or your myelogenous cell lineage of the bone marrow and then spreads throughout the body so that the WBC are produced in many extramedullary tissues, especially in your lymph nodes, spleen, and liver. So this is the table. That's what I mentioned to you guys. You know, Dr. Bautista always loves to give you tables so you can easily study. Okay? Acute leukemias, both myelogenous and lymphoid in tissue, we call that your AML and your ALL. Chronic leukemias are your chronic myelogenous leukemia and chronic lymphocytic leukemia. Okay, so this is the difference of the two lineage where you produce those type of cancers in your blood. Why do you mean blood? Because if you remember, my dear students, myeloid lineage produces your RBCs and also your platelets. So if you have reticuloblasts or immature RBCs and platelet, that connotes there's a problem also in your myeloid stem cells. Okay? So I think that's the lecture. I'm now open for your questions and let's answer your questions. Thank you for listening and have a blessed day.